Lima!
Hi, Khalida.
Hey, are you ready for Confessions of a Midwife?
I am. I'm ready as I'll ever be.
Great. So, what exactly is your job role, Lima?
So I am a midwife here on the high-risk labour ward. And that means that I look after all women who are having a high-risk pregnancy. So for various reasons, they may have developed some complications in their pregnancy. There may be a problem with mum. She may have some existing medical needs that she needs to have monitored throughout her pregnancy. Or there may be some concerns about baby's growth, or about any kind of fetal problems as well too. So for some reason, mum and baby both need monitoring throughout their labour.
Interesting. So can you just give me a tour of this room?
Yeah, so this is your kind of typical labour room. I'm just going to shut the door quickly because otherwise we're going to have people coming in. So all of the rooms are en suite. Mum has a shower room and a bathroom.
Can we have a look?
Toilet in here, we can. Yeah.
Ooh, fancy. So we've got a shower, toilet.
Yes. We have our labour bed, which is a very active labour bed that can go into lots of different positions for mum in labour. You can be on all fours, you can be squatting, you can be in various different positions on this bed to try and encourage active labour positions. We have over here some of the monitoring that mum will need if she's on the obstetric ward. So blood pressure, temperature, pulse, and what is called a CTG, which is how we monitor the well-being of the baby throughout the labour. So this machine will monitor the baby's heart rate, and it will also monitor the timing and the frequency of the contractions. And that, generally speaking, is something that we use. We either have intermittent monitoring, where we take it on and off, or we have continuous monitoring, where it has to be on for the duration of the lady's labour.
Interesting. So this is called a CTG machine.
Yes.
Yeah. And this big thing at the back?
This big thing at the back is baby's resuscitation cot. So after, if baby is born and baby needs assistance from the neonatal team, for example, or the baby needs some help at the time of delivery, baby will be brought straight here to the cot. If baby is well and baby is crying, we deliver baby onto mum's chest, so we do delayed cord clamping. But if baby needs assistance, baby will come straight to the cot. And we have everything that we need here in terms of oxygen, in terms of basic airway equipment that we might need to do some basic airway resuscitation on baby if that's needed. And we can also keep baby nice and warm because there is a lamp, a nice warm lamp here that keeps baby nice and warm. Sometimes babies can lose heat quite quickly. We can listen in to baby's heart rate and baby's breathing with our stethoscope. We might need to suction baby's airway if there's anything in the airway. So it's all of our basic equipment that we can deal with so that we don't have to take baby out of the room and baby can stay in the room with mum and dad or birth partner and dad whilst they're having their initial checks after birth.
Okay, great. So today what I wanted to ask you about was pain relief.
Yay!
Okay, so there's plenty of options.
There are lots and lots of options for pain relief.
But what do we start with? What's the first pain relief that's offered to a client?
So the first pain relief that is offered to client, well, obviously it's very individual for each lady. It will depend on the severity of the pain. So the midwife will be having a conversation with the client about what type of pain are you experiencing, when did it start, on a scale of 1 to 10 or a scale of 0 to 3. 3 being the most intense pain you've ever felt in your life, or 10 being the most intense pain you've ever felt in your life. Where would you say you are on the scale? So that is a tool that midwives would use to assess, is it mild, is it moderate, or is it severe pain? And then if, say for example, it was on the milder end or the moderate end, the first thing that we would offer is oral analgesia, so tablets.
So tablets such as?
So tablets such as paracetamol and dihydrocodeine. Now, people hear paracetamol and think, oh, you know, paracetamol is not enough for somebody who's in labour. But actually, when you give paracetamol and codeine together, the efficacy of the paracetamol is increased. So it actually makes it slightly stronger. So paracetamol and dihydrocodeine we give together. Often mum will see 4 tablets in the pot and be a bit scared. It's safe to take that dose in early labour.
So there's no side effects taking paracetamol and dihydrocodeine?
No, we give those both safely together in early labour. So that would be the first thing that we would offer.
And what would be the second step now?
Then the second step, say for example, pain was increasing, mum had already had some paracetamol and dihydrocodone, and things weren't getting any easier. There's a choice. There's always a choice in obstetrics. We're never going to make women have one option of pain relief over the other. It's about a discussion about what the best form of pain relief is for them at that point in their journey here with us in labour ward. So at that point, I would either discuss with mum about thinking about Entonox, which is gas and air. People will know Entonox as gas and air. On the labour ward, it comes through a pipe from a wall, from the central supply in the wall. So it's not like the old-fashioned days where you have a big cylinder and the cylinder might run out. It's a continuous supply, so it never ever runs out. And you can't really ever take too much either.
So is there any side effects taking this?
There are some side effects with taking Entonox. So it can make you feel quite woozy. It can make your mouth very dry. Sometimes it can make you feel really euphoric and really like lots of people have a good time in it. They're laughing, they're joking, they're able to distract themselves from the pain. And other people just find it too disorientating. It makes them feel too woozy. It's not a nice feeling for some people. Some people like that feeling of being woozy and not feeling quite in the room, and other people don't like that sensation.
Does it have any effect on the baby?
No, it doesn't have any effect on the baby at all.
Okay.
So from a pharmaceutical point of view, we don't really understand how Entonox works on the body, but we know that it is very rapidly metabolized, so it doesn't last very long in your system. And again, it's about that, some breathing in something that evaporates quite quickly. It helps you deal with the intense pain of a contraction. It's very short acting. When you stop breathing it in, it evaporates and you don't have those effects anymore.
Now, can you show us how a client is meant to use this Entonox?
It's controlled completely by the mum. Mum will hold the pipe. She'll put the whole pipe into her mouth and it makes this type of sound. So when you breathe it in, it makes this type of sound. You keep the pipe in your mouth and you exhale into the pipe again. So it's very much... And during the contraction or surge, mum might take 5-6 breaths of the gas just at the peak of the contraction. As mum starts to feel the contraction or the surge easing away, you can stop breathing the gas.
So you should only take the gas whilst you're having a contraction?
Exactly, yeah.
Okay.
So we tell mum, you can sense that the next contraction's coming. Okay, so get your gas in your mouth, start to take some deep breaths in and out. Quite often you will see mums will close their eyes, they'll really focus on the breath. It helps them to slow their breathing down. We say take some nice, slow, deep breaths.
So it should be slow, not fast.
Not fast. No, nice and slow.
Okay, so nice and slow.
Nice, slow, deep breaths in and out. And usually you see mum physically relaxing. And then as the contraction starts to peak and fade away, we encourage mum to stop.
Now, for the dry mouth, would you advise to stay well hydrated after you take the gas?
Absolutely. So in between each contraction, when you've finished using your gas, we usually offer clients some water. You can put on some lip balm, you can wash your mouth out, you can brush your teeth, you can just take some continuous little sips as well too, if that's helpful. Now, it does give you quite a dry mouth.
With the gas, can you mobilise in the room?
Yeah, absolutely. You can mobilise in the room, you can be on the birthing ball, you can be standing, you can be squatting, you can even be in the pool if you're using hydrotherapy for pain relief and use the gas at the same time. The pipe itself comes out from the wall and we can move it around to different locations.
Okay, so you can move
for
around
example,
the
in
room.
our pool room, we have another port that's right by the pool, so we can move the whole pipe over and mum can have the gas by the pool.
Okay, interesting. Yeah. Thank you. So now, if the pain's getting stronger and now the gas is not having as great effect as it did initially, what's the next step of pain relief?
So the next step that we would discuss with mum is something, for example, like pethidine. So pethidine is an opiate-based drug and it is given as an injection. Okay, so it's drawn up in a syringe. It's checked by 2 midwives, and it's given as an intramuscular injection. So that's into a muscle. So either in your arm, in your leg, or in the glute muscle at the back.
Okay, so we look for fatty areas.
Nice muscly area, yeah.
Great.
And pethidine is a really, really good form of pain relief. I think a lot of people are scared of pethidine because they're worried that it will affect their baby in some way. And I hear women say that they're worried about losing control or somehow not being able to be part of their labour still. And what I would say is that all of the analgesia options that we have, none of them will take the pain away 100%. So they will all affect different people differently, and that depends on your metabolism, it depends on your BMI, it depends on whether or not you've had opiates before in your life, and because the body will react differently to when they have opiates for the first time, for example. Or somebody might be very used to having opiates because they've had a chronic pain problem, and actually a small dose of pethidine probably won't do anything. They would need something stronger. So again, it's depending on the lady herself and her background.
Okay.
But usually pethidine is very, very safe. We recommend that you don't have pethidine towards the end of your labour. And the only reason why that is because if we give pethidine at the end of the labour and baby's born within a quick period of time after the pethidine has been given, it can sometimes make baby a bit sleepy. Now, it doesn't harm the baby, it doesn't have any long-term effects on baby, but if baby is sleepy, it can make it difficult to feed the baby, and it can make it difficult for us to assess the baby and how awake the baby is and how responsive the baby is. But it doesn't harm the baby. If you take pethidine and all of a sudden you suddenly dilate to 10 centimetres and your baby is born, you're not going to have permanently damaged the baby. Baby just might be a little bit sleepy. So you might find those first couple of hours, it's
Baby's a bit
difficult to
drowsy.
feed baby, and
Okay.
baby might be a bit drowsy.
Is that the only side effect to taking pethidine?
I would say from mum, obviously, you can get a little bit nauseous with pethidine.
But
So it
along
can
with the
make you feel-
pethidine, you give an anti-sickness,
that's
don't
what
you?
I was just about to say. So because of that, we give an anti-sickness injection as well. And the reason why we give pethidine as an injection is because when you're in labour, the absorption in your stomach is not as effective. So if we carry on just giving oral tablets throughout the progression of your labour, we can't be sure how well you're going to absorb that, because there's changes in your GI tract as well when you're in labour and you're having those very strong contractions. So it's better to give something via an injection that we know it's going to be absorbed and get into the bloodstream a bit quicker. So I would say pethidine is really, really good for early labour, and it's really good for the first stage of labour.
Now, what stage can be given?
So it can be given really at any stage. Like I said, the only time that we wouldn't give it is if we knew birth was imminent.
Okay.
So we thought baby was going to be born within the next hour or so. But any other time up until that, and it can be given on more than one occasion. So if mum has some pethidine in early labour, and it helps her to relax, it helps her to be able to go to sleep, for example, for a couple of hours if she's been awake all night. Once your body relaxes and that fight or flight, that rush of adrenaline that's been going around your body calms down a little bit, women often dilate. So often you'll give pethidine to women, they'll go to sleep for a couple of hours, they'll be a little bit more relaxed, and when they start to contract again, they'll be a bit further on in terms of their dilatation because they've had that period of
Relaxing, and the muscles just
relaxation,
relax.
and the muscles relax, exactly, yeah.
Okay.
So I would say pethidine is actually it's a really good drug to take for pain relief in early labour or in the first stage of labour. Not recommended so much towards the end of labour. Yeah.
So it's completely safe.
Yep.
To take pethidine once.
Yep.
in.
And we give an anti-sickness
Along with
injection at the same time, just in case you have some nausea from the opiate side of the medication.
And with the pethidine, can the woman client still move around?
Absolutely. She can
still
move
stay mobile?
around, she can be on the ball, she can do all of those things that she wants to do. Yeah.
Okay. Now, the pethidine is slowly having no effect sometimes, and women want something a little bit stronger.
Yeah.
So what would be the next?
So then the next stage would be an epidural.
And is that the final?
Yeah, that is more or less.
You can't top the epidural.
No, it is. But again, if you decide to have an epidural as part of your labour plan, as part of your birth plan, you'll be seen by the anaesthetist who will go through the
So
risk.
anaesthetist, that's a doctor.
An anaesthetist is a doctor who specialises in anaesthesiology, and they are the doctor that will actually come and give you the anaesthetic. So it's a form of local anaesthetic that's injected straight into the lower part of the spine of the back. Yeah.
Yeah.
So here, sort of halfway down your back. Anaesthetist will tell you that it takes away about 75 to 80% of the pain, not 100% like I said earlier. And actually that's quite beneficial. That has some benefits for mum, because if you have some feeling during the second stage of labour when you're actively pushing, you have a focus to direct the force of your pushing. If you are completely pain-free and you can't feel anything at all, it's associated sometimes with a longer second stage because you're pushing for longer, because you don't have that sense of feeling of where to push. So when you have an epidural put in, you have to sit at the edge of the bed, and the anaesthetist will ask you to curl your back like an angry cat. So you'll be asked to curl your back, drop your shoulders and look down towards the floor. You will have somebody in front of you, your midwife and your birth partner, and you will hug your pillow. And by hugging your pillow, it gets you into a good position and it opens up the space in your back for the anaesthetist to be able to put the injection in. Now, a lot of women are a little bit frightened of their contractions carrying on when the epidural is being put in, and they do carry on because you can't stop your contractions. But what we say is that when the contraction's coming, we will stop and we won't do anything until we're between contractions. And usually we will place the Entonox pipe somewhere very near mum's face, so that in the unlikely event she starts to have a contraction during the insertion, she can just move her head and take a couple of very gentle puffs on the gas, so as that she stays in the right position for the anaesthetist to insert the epidural anaesthesia into the back. Very important at this stage that you stay still, because there is a needle in the back at that stage. So it's a very, very fine, technically challenging procedure that mum needs to be able to cooperate with in order for it to be really successful and for it to work.
Now, with the needle's taken out and
Yes,
just a plastic.
absolutely.
Yeah.
So the needle is taken out, and what's left in the back is a piece of very, very thin plastic tubing, and it comes up all the length of the back, and it gets a little plaster that comes up and secures it to mum's back, and it stays here in the front of mum's chest. It gets attached to a pump, and that pump will give the client a set amount of epidural dose.
Now, with the epidural, in preparation for the epidural, is there anything that needs to be done before?
Yes, so it's something that's actually needs to be given a lot of consideration. And I would say sometimes mums come in and they have it in their birth plan and they're very set that they would like an epidural, but actually it does take preparation. So if you were coming for a minor operation or a minor procedure, you would have preparation. And that's exactly the same. It is like a mini minor procedure. It's done in the obstetric room, but obviously we have to have taken the consent from mum and have the consent form completed. We need to have some bloods taken on mum, specifically a hemoglobin count and a platelet count. That's very important information. The anaesthetist needs to know whether it's safe or not to put the epidural in. Generally speaking, the mum needs to have a cannula, which is a small plastic tube that sits in a vein in the hand or the lower arm to provide medications like fluid, or in the unlikely situation that there was a problem with the epidural, that the anaesthetist could give other drugs that the client might need. One of the things with epidural is that it can lower the mum's blood pressure a little bit. So you have to have blood pressure monitoring on. And
Continuously.
And we usually do give some bolus of IV fluids, again, to augment and just to make sure that that blood pressure doesn't drop low and mum doesn't feel woozy or anything like that. So all of those things have to be in place. We have to have the anaesthetist available. So the anaesthetist on the obstetric ward is not just for the obstetric ward. They're also covering ladies who are having cesarean sections in theatre, and they might also be covering other anaesthetic responsibilities in the hospital as well.
So sometimes it can be a bit of a wait when you are requesting an epidural.
And that wait might be because the bloods aren't ready, or it might be because the anaesthetist hasn't been able to come and counsel you and get proper consent, or it might be that there's some delay in terms of that the anaesthetist is looking after other acutely unwell patients elsewhere in the obstetric department.
Okay, interesting. Now, the side effects to an epidural. I know the anaesthetist will go through a consent form and discuss, but can you just give us a rough idea?
So I would say for most mums to be aware that it changes the focus of your labour, definitely having epidural anesthesiology or anaesthesia. I would say some ladies can have a few different experiences. They might get good analgesia down one side of their body and still be able to feel some pain or pressure on the other side of the body. If that was the case, the anaesthetist would come back and assess the lady and take some steps to try and relieve that. I would also say that it affects your mobility. So again, some ladies are able to move around the bed, they're able to go on all fours, they might be able to sit at the side of the bed on a ball, for example. But the longer you have the epidural for, it accumulates. So if you have your epidural for 6, 7, 8 hours potentially of your labour, by the end of that time, your legs get very heavy and you would find it hard to mobilise. So it affects your mobility. It affects your ability to be able to empty your bladder, get up and walk to the toilet and empty your bladder, because again, you don't have the sensation that your bladder is full. So we would offer our ladies a indwelling urinary catheter, so that we can empty the bladder and we can keep an eye on their fluid balance, what's going in and what's coming out, to make sure they're well hydrated. They're the main things I would say, affecting the mobility and affecting your bladder.
Now, when a lady has an epidural sited, she's most of the time they're bedbound because she can't really mobilise much.
Yes and no. We do try and promote ladies moving around the bed.
Okay.
For those ladies that have good block,
Yeah.
they're able to move their legs. We still encourage them to be in upright positions, maybe like a throne position, like you're in a chair.
Okay.
Or we do try and get them onto lying on their side, for example. One of the other side effects one of the other things that you have to be aware about with epidural is that you don't only lose the ability to kind of move your legs, you lose sensation. So you can't feel, for example, if you're sitting and your bottom's getting sore, or you can't feel, for example, if you're sitting and your skin is wet from discharge or the baby's amniotic fluid leaking out. So it's very important that you keep moving with an epidural, because to prevent pressure sores,
the midwife will try to
absolutely
change positions.
Because you are at risk of pressure sores with an epidural. That is, and going back to the main sort of side effects or the main kind of contraindications to it, I would say that's something that women need to be very aware of. So it's very important every 2 hours to change position when you have an epidural. It might be the midwife rolls you onto your side, checks your back and skin, and then rolls you back again. Or it might be, if you have got really good movements in your legs, you might be able to just pop onto all fours, even just for 10 or 15 minutes as a change of position. And that's really important as well too when you have epidural.
Okay, thank you. Now, lots of women complain of backaches after an epidural.
Yeah.
Is there any relation between...
There's no evidence, there's no scientific evidence that epidural causes long-term back pain. And I think there's been quite a lot of, when the anaesthetist, I hear counselling women, there's a lot of good evidence, scientific evidence out there that it's not associated with long-term back pain. You might have a little bit of localised discomfort, at that area because you've been given some local anaesthetic, you've had a small plastic catheter in your back, so it might be a bit uncomfortable just locally at the insertion site for a day or two, but you shouldn't have any long-term problems with chronic back pain as a result of an epidural.
Okay, wonderful. Now, when it comes to mum's 10 centimeters, time to push, as you said before, sometimes you have no sense, you have no feeling. How would mum know when she needs to push?
So with an epidural, we would be doing continuous monitoring of the baby. So again, back to our CTG machine. So we would be timing the frequency and the duration of the contractions along with the baby's heart rate. So often mum can still feel a bit of change in pressure. She might still feel some pressure up here or some tightness in the back. And also we will tell mum as well too that she's having a contraction, and we will help her to push at that stage. If she doesn't have the sensation or the feeling herself, we will tell her when it's time to push and how long to push for.
So the chances of having a normal delivery with an epidural is pretty high
really
still.
high. Lots of women have a vaginal delivery with no complications with epidural.
And how long does it take for the epidural to wear off after?
It depends on how long you've had the epidural for and how heavy your legs have been, what your response has been to it. I would say anywhere in the region of about 4 to 6 hours after the baby is born and the epidural has stopped, that you start to get sensation back in your legs again and you're able to get up and walk around.
Brilliant. Thank you very much, Ema.
You're welcome.
It's been great. I'm sure the ladies have learnt so much today. I hope we see you again.
Yeah, definitely. Thanks a lot.
Great. Bye.